5 days. And she had a fever with skin rashes 1 year back. It was diagnosed to have a Kikuchi's disease. And she had associated retinal vasculitis for which she was treated with systemic steroids elsewhere. Subsequently, she was treated with immunosuppressives using methotrexate followed by azathioprine. And along the course, she had multiple superadded skin infections treated with multiple antibiotics at presentation. She was on treatment with tablets-azo, leflunomide and aceclofenac. On examination, the patient had multiple papulopustular eruptions on the face and extremities and skin. This is at the time of presentation to us. This was 1 year back when the patient had multiple skin lesions and cervical lymph node biopsy diagnosed to have Kikuchi's disease. And in addition to that, she had hand deformities, the joint swelling and erosive arthritis. Ophthalmic examination, visual acuity in the right eye was 6.9, left eye was 6.6, intraocular pressure was within normal limits. Anterior segment examination revealed flare and traces of cells. There was a broken posterior synechiae with pigment deposits on the anterior lens capsule. Fundus examination, she had vitritis and vitreous haze 1+, because she underwent a fundus fluorescent angiography which revealed diffuse perivascular leak in both eyes. The treating immunologist told us whenever they step up this, either the immunosuppressive or the steroid skin lesions worsening. So he specifically told us not to put her on systemic steroids, so we treated her with periapical transdermal acetonide injection for both eyes. She received 2 doses and ocular symptoms have improved. And 3 months later, she presented with worsening of inflammation both systemically as well as in the eye. We can see the papulopustular eruptions, which is more of pigmented in the extremities. This is also on the legs. In the legs, we can see the indurated lesions with pustular eruptions. The pus was pouring out in the legs. At this point of time, she had traces of hypopia in the right eye. Left eye, she had hypopia with non-granulomous anterior uveitis. Fundus examination showed areas of retinal infiltrate as in the form of multifocal retinitis. Left eye vitreous haze was there. In view of cold hypopia, multifocal retinitis, associated skin lesions, we made the diagnosis of Behçet's disease. At this point of time, clinically, we ordered HLA-B5 came positive. And we insisted the hematologist to start her on cyclosporine because of the multiple superadded bacterial infections. Was a little bit hesitant initially, but we treated the patient with systemic steroids, cyclosporine with appropriate antibiotic cover. Within 2 weeks, we could see the resolved skin lesions in the extremities and also complete resolution of the eye inflammation in both eyes. She was doing well with cyclosporine and systemic steroids. On 6/11/2013, she presented when she was on tapering dose of systemic steroids, that is alternative day regimen, along with cyclosporine, presented with decrease in vision in the left eye. She said had mild discomfort, maybe fever 2 days back. She was not paying importance to the history. On examination, visual acuity in the left eye was 6/18, intraocular pressure was normal, right eye examination was absolutely fine. The left eye revealed presence of hypopia with multifocal retinitis associated with hemorrhages, vitreous cells and hyperreflective apose on the inner retina. So we thought, having the known case of a Behçet's, there is a reactivation of Behçet's disease, and since she gave history of fever, we ordered for the complete hemogram and the total count was increased, that is 13,000. This could be maybe due to the long-term systemic steroid therapy, and we stepped up the systemic steroids to 60 mg. In view of fever, and we put her on additional empirical antibiotic therapy as well, and topical steroids and cycloplegic were continued. She comes back with next day, there was a worsening of inflammation in the left eye and also the appearance of new lesions in the right eye. So we did the AC tab to rule out any associated infective agents, and systemic antiviral also has been added. 3 days later, when we got the report, the PCR for the viral and the bacterial genome came negative. 4 days later, she comes back to us with pain and swelling, the infected boil kind of a picture in the chin. we did the culture. Culture and sensitivity showed Staphylococcus, methicillin sensitive Staphylococcus aureus came positive, which was resistant to ciprofloxacin. We changed the antibiotic from ciprofloxacin to Novoclox, that is ampicillin with cloxacillin. Within 24 hours, the lesion started disappearing. This is after 48 hours, complete resolution of the inflammation was noted in this patient. But on FFA, we noticed the disc staining with diffuse capillaritis. The perivascular leak was seen in both eyes. Continued with systemic steroids and cyclosporine with antibiotic therapy. Coming to the discussion, Kikuchi's or histiocytic necrotizing lymphadenitis is characterized by the presence of fever, lymphadenopathy and neutropenia. Diagnosis by the lymph node excision biopsy. The exact etiology is unknown. Could be autoimmune hypothesis, where we have seen Kikuchi turning into an SLE, but however there are no reports Kikuchi turning into a Behçet's disease. The diagnosis of Behçet's is clinical based on the presence of characteristic ocular and systemic manifestations. An infectious etiology must be ruled out even in patients who have diagnosed have a case of Behçet's disease as seen in this patient. We'll move on to the next case. A 58-year female diagnosed have a viral retinitis and panuveitis, not responding to the treatment with antiviral and systemic steroids, referred to us for second opinion in July 2013. Examination of the right eye was normal. In the left eye, best corrected visual acuity was 260. Anterior segment examination showed the presence of circumciliary congestion and medium to large keratic precipitates associated with AC cells. Fundus examination of the right eye was normal. In the left eye, there is gritty medial haze and mild hyperemia of the disc, and the associated with this pallor is noted, and there is a sclerosed vessels with multiple areas of retinal opacification is characterized in the form of multifocal retinitis. The close follow-up of the image where you can see the sclerosed vessels with retinitis and two other lesions of retinitis. So this is a multifocal retinitis. We thought this is maybe a atypical form of toxas in the form of pyrrhus arteriolitis associated with retinitis. We got the investigations done and OCT showed the presence of ARM and hyperreflective echoes in the inner retinal layers and hyperreflective echo corresponding to the areas of arteriolitis, where we say the classical pyrrhus arteriolitis. And whenever the toxo lesions heal or during the thing, there is a characteristic ARM formation over the retinitis lesions. So when we got the investigations done, the IgG came positive. IgG was 500 international units per ml. We did the ACTAP, came negative for the viral genome, HSV, VZV and CMV. Toxoplasma B1 gene came positive, confirming the diagnosis of toxoplasmosis. We did a confocal microscopy for an academic interest, which showed central globular dendritic goes well with the toxoplasmic kind of a retinochoroiditis, which we've seen it earlier in our study. So here the picture must have been altered, maybe because of the systemic steroid use without an appropriate antimicrobial therapy for toxoplasmosis. So when the patient presented to us as in the form of multifocal retinitis with pyrrhus arteriolitis. Coming to the toxoplasmosis management, systemic antitoxo treatment with sulfa, pyrimethamine, folic acid to be started first, followed by systemic steroids. The same way, systemic steroids should be tapered first, followed by antimicrobial therapy. Topical steroids and cycloplegics have been used for associated anterior segment inflammation. So this particular patient received 2 weeks of systemic antitoxo and systemic steroids, but we did not find much improvement. So at this point of time, we are given additional intravitreal clindamycin with dexamethasone with 1 milligram in 0.1 ml with 400 microgram of dexamethasone was given. Patients received 3 doses of injections, following which you could see the resolving retinitis in this patient. Coming to the discussion, so we presented 2 cases of multifocal retinitis. One had like cold hypopia with multifocal retinitis with a reasonably good visual acuity, secondary to autoimmune uveitis. Whereas the second one also had multifocal retinitis. Here the patient is symptomatic, associated with a decrease in the visual acuity, and we could see the alterations in the retinal changes with decrease in visual case illustrates the possible consequence of systemic steroids in infection with toxoplasmosis. Clayher and Rush et al. Have reported similar cases, whereas Rush reported fulminant toxoplasmic retinochoroiditis following intravitreal triamcinolone acetonide in a case of idiopathic uveitis. The picture is similar to our case. So the classical therapy consisting of triple therapy where we use sulfa, pyrimethamine and systemic steroids. In immunocompromised individuals, preferable to avoid the systemic steroids and treat them with antitoxo drugs alone. Suppose if the patient is pregnant, spiramycin is the drug of choice. Whenever we see a retinitis, it's most commonly associated with infective uveitis. We need to rule out infective etiology before we consider an autoimmune. Atypical multifocal retinitis, in addition to serological testing, the molecular diagnostics help us to confirm the diagnosis. Systemic steroids should be started only after appropriate antimicrobial therapy. Intravitreal clindamycin can be used as an adjunct in addition to the systemic medications in a case of atypical multifocal toxoplasmic retinochoroiditis. So, take this opportunity to give your feedback. SMS to 92200 92200 regarding the feedback of this IC, and also we invite you for the annual meeting of the Uveitis Society of India, that is November 22nd and 23rd. It's going to be in Delhi. Dr. Shashir, would you like to say?
Yes, invite everybody, announce the meeting in November this year. Please, you can visit the website also, and you can email to me the email. There's a questionnaire, there's a quiz in the flyer on the back side. You can identify those 7 tourist spots, and you can email to me in good time, and the best 3 entries will get free registrations. So that's a bit of a...
So the bonus for the yearly registration. Thank you for your attention. Do you have any questions? Dr. You had a question for the first speaker?
Just wondering, the first photograph shown by Dr. Balamurugan, I was wondering whether the patient had a combined vascular occlusion, both arterial and venous.
Dr. Balamurugan. Can you go back? Can you go back to the presentation? Please. Any other questions? If it is not there, I would like to share the few interesting cases. Dr. Somshila was supposed to present challenging cases on scleritis. I think she got stuck in the traffic. She's not able to reach us on time. So in this, I would like to share a few of our experiences with scleritis, which I made it in the last. Any other questions for any speaker? Yes.
How long is the antiviral therapy given, either the gel or the oral, for the hypertensive uveitis or Fuchs heterochromic? How long would you continue the antiviral?
In terms of the HSV and BZV, we've given up to 2-3 months. We've given in those patients. But with respect to ganciclovir, the cost of the medication is a problem. So many of the patients at max we've given for 6 weeks, not beyond that. But there is a nice paper by Dr. Chi from Singapore where they have given it for longer periods of time. But the minute you stop the medications, you do get back a recurrence. So there is no defining period as to how long we could give these medications. But viral, we have given it for longer. HSV and BZV, we do give it for longer periods of time.
So you give the antiviral, you give the anti-glaucoma. Do you also give the steroids along with it? Topical steroids, or do you want to just see if the antivirals will take care of it?
Most of our patients, the pressure comes down only when we start topical steroids.
Yeah, they would anyways.
Yeah, but as a maintenance, we do keep these patients on topical NSAIDs. We've had very good experience with one patient with CMV anti-uveitis who did very well with just topical NSAIDs for quite some time. I mean, this is after the acute phase is over. I mean, when the pressures are high. And after you get it down, to keep them on topical NSAIDs for a longer time did help.
Any experience with avoiding the steroids? Just giving the
No,
antivirals
all
and the
our patients
anti-glaucoma?
required steroids too, because the pressures are so high, and it's like 40 or 50 on that day. And the minute we start Bradford or dexamethasone, the pressure drops to 40 or 60.
Yes.
So that much of a difference is probably because of the tuberculitis. And that instant drop in pressures comes down immediately.
There's a Cipla has come out with a
that is much
which is very cheaper.
Much
So
lower.
many of my patients with CMV retinitis are on that Valgan.
Right.
It's called Valgan. No, it's called just called Valgan. That's it. But it's very much cheaper and patients are able to afford it.
We have, because earlier was with Roche and that was very expensive.
Very expensive.
And now it is. But even then it is difficult to define how long the patient needs to continue. We did try to taper the medications to 450 once a day and keep them on for a longer time. But then I think eventually we had to get back to just the gel and NSAIDs.
Dr. Balamurugan, you had the question. Dr. Kumar was asking you the first case which you presented in the Western Isles, the combined arterial vein occlusion. Can you? He says it's a combined.
Yeah. But we diagnosed it well.
Can you switch on the mic, please?
First, the initial diagnosis we made was combined occlusion bilaterally. It was so dramatic and there was a preceding history of fever. So probably the thought we had in mind was probably it would be a viral unknown entity. And since we had a clustering of patients in a 6-month period, we did a workup with molecular technique that yielded to that. Whenever we encounter a case of hemorrhagic viral retinitis or neuroretinitis with sparse vitreous cells or any scenario, then we thought that we should include retinal also in the differential test.
Thank you.
What should be done in the cases of recurrent anterior uveitis occurring alternating eye? Patients having a uveitis in one eye for few days, getting resolved, then he is getting uveitis in other eye for few days, then resolving. And all these systemic investigations are normal.
You found for seronegative with seropositive HLA-B 27, most of them in young patient alternating. If they will not be symptomatic, that is the most common.
So that should be continue for the long term. Once getting resolved, and should have to be
No, if it's longer time, you need to look out for the cause. And if it's not, you have to go for the, depends, if it's only taking control with topical medication, there are no side effects, watch for the glaucoma or the cataract development, then you can continue with it. Or if it's recurrent, alternating, it's persisting more than 3-4 months, I would like to investigate and go for immunosuppression.
One last question.
Please.
For all these cases of viral retinitis that you showed and Kalpana showed, do you think it's a must before starting treatment to do a diagnostic tab? And then if you do it, do you prefer PCR or Exciton? Because probably the cost will be less for Exciton. They cover everything in one test.
So the ideal thing will be the real time or quantitative PCR where you can really quantify the amount of the organism present and titrate with the treatment. If it is not that, the nested PCR will be the second option. I think Dr. Pushma may be the better person to answer to that question. I vote quantitative first, the nested second, and maybe the third is the screening tool, what you say, the Exciton.
Yes, ma'am. That is the way. Actually, if you are looking for the viral etiology, what was published last year by Infectious Disease Society of America, that you should go for a quantitative PCR. You should have a copy number, then you can comment upon it. That what exactly, how, because in case of viral PCR, it has got some prognostic value also. It goes down with
Engagement, and you can titrate with the treatment.
So you would not start treatment without doing that, or would you just start based on your clinical judgment also?
See, basically, we try to start with empirical. If the patient is not responding, then you go. But it depends the affordability of the patient. Especially for HSP and BZB, we can go most of the times with the clinical judgment. Where the CMV, where the cost of the treatment is very high, we need to have a PCR confirmation. Then you can subject the patient for expensive treatment. We have 5 more minutes. I'll share 2 cases. The scleritis, where the patient presents with dull aching, deep-seated pain which wake them from the middle of the sleep, can be associated with sclerokeratitis or the sclerouveitis. Here, a 20-year female presented with recurrent redness and pain. The best corrected visual acuity was 6/9. On examination, you can see the conjunctival ulceration with scleritis and also the keratitis. And she was treated with topical medications for 6 weeks. On investigation, positive Cianca, immunofluorescence, diagnosis of vaginas was made, and she was treated with pulse therapy of cyclophosphamide with intravenous methylprednisolone. Following 4 days, we could see the resolution of the scleritis and healing keratitis in both eyes. Here, a 13-year-old male presented with history of redness and watering in both eyes. He had consultation elsewhere, treated for allergic conjunctivitis for 6 months. He also had a joint pain since 1.5 months. Was really sick when he came to a clinic. He was in the wheelchair. So, had a conjunctival as well as episcleral and part of a scleral condition with some part of a keratitis. Patient was started on topical steroids. Suspicion of vaginas was made and was investigated further, and Cianca came positive. He had proteinuria, bilateral maxillary sinusitis associated with increase in blood pressure. Referred to the immunologist. Following the workup, he underwent a renal biopsy which showed fibrinoid necrosis with glomerular crescent, confirming the diagnosis of complete vaginas. He was treated with IV methylprednisolone and cyclophosphamide, following the confirmation of the quasi-immune glomerular nephritis with vaginous granulomatosis. Subsequently, he was shifted to oral steroids and azathioprine. Patient was doing well, and he was in the remission phase, and the father insisted he has been taking this treatment for so long, so he wanted to stop the systemic steroids. He insisted. So the azathioprine was on 75 mg, and anti-hypertensive medications were continued. From 2009 to 2013 was medication, so then we stopped the systemic steroids. Then he comes back with pain and redness in the eye with the recurrence of scleritis and keratitis. When we repeated the thing, he had proteinuria, ANCA titer has gone up to 94, and he was restarted on systemic steroids and azathioprine dosage was stepped up. Here, a 50-year-old gentleman presented to us with a history of watering in the right eye since 1 year. He had nodular scleritis and also the iris nodules in the eye associated with inflammation in the anterior segment. On systemic examination, he had leonine facies, madarosis, depressed nasal bridge with broadening of the nose, suggestive of Hansen's disease. He underwent a skin biopsy which showed numerous lepra bacilli by 5-Paraco strain. So, diagnosis of multibacillary leprosy was made. He was started on antireprotic treatment, systemic steroids along with topical steroids and cycloplegic agent. Hansen's, we need to keep it in mind. Even though we have eradicated, the patients can have corneal anesthesia, can present with delayed complications secondary to lack of thalamus and exposure keratitis. This was at presentations. This is 2 weeks following treatment. This is 1 month showing the resolution of the granuloma in the anterior chamber. The similar thing was noticed in the left eye. A 45-year-old female presented with history of redness and pain in the left eye, had an episcleral and the scleral condition, so nodular anterior scleritis associated with broad-based posterior synechiae in the eye. Fundus examination had multiple nodules in the choroid, suggestive of a choroidal tubercle. Mantle came strongly positive. Quantiferon tibialis also was positive, and she was put on ADT and systemic steroids and topical steroids and cycloplegic agents, following which we could see the resolution of the scleritis, nodular scleritis, and resolving choroidal tubercle in the eye. This is a resolving granuloma. And a 50-year-old male presented to us with redness in the right eye since 1 month. He gives history of trauma. He was treated elsewhere with systemic steroids, so did not show improvement. On examination, he had diffuse episcleral and scleral condition with multiple nodules. There were 3 nodules in the anterior segment with yellowish in color. Was started on topical antibiotic and systemic antibiotic. Did not respond. Incision and drainage was done. In that, gram stain, KOH and AFB were negative. PCR for the eubacterial genome came positive, and culture showed methicillin sensitive staphylococcus, which was sensitive to vancomycin and chloramphenicol only. This is following under IND. We could see the discharging us from these lesions, and this is following treatment with topical vancomycin and systemic chloramphenicol. This is after 6 weeks. You could see the complete resolution of the scleritis in this patient. So this is whenever patient presents with trauma and multiple nodular anterior scleritis, we need to rule out the infective etiology. Here, a 90-year-old male presented following 6 months cataract surgery, pain and redness in the eye. On investigations, smear was negative for microorganisms. We made the diagnosis of surgically induced necrotizing scleritis. The patient was put on IV methylprednisolone along with IV cyclophosphamide therapy, followed by immunosuppressive therapy. This is 4 weeks later. We could see the resolution of the sins in this patient. So whenever we have to make the correct diagnosis of scleritis, and then we can quantify the scleritis. There are 2 grading systems is available, either the photographic by Nedersen or McCluskey scoring systems, and then we need to rule out associated systemic disease, especially an underlying autoimmune which could be fatal if we don't detect it on time. So coming to the therapy, first you prefer to start them on systemic NSAIDs. If they don't respond, then switch over to systemic steroids. If they're not responding, then to consider immunosuppressants. Even if this is not responding in autoimmune cases, we switch over to biological agents. Especially in a necrotizing variety, if they're not responding, the sclera is melting, scleral patch graft can be done. So all the cases of scleritis we need to investigate. Only recurrent cases of episcleritis we need to subject them for investigations. In addition to immune-mediated diseases, etiologies such as infection must always be kept in mind in our situation. Careful clinical assessment with a review of complications of the ocular disease, systemic disease, and monitoring of the systemic therapy is essential in scleritis cases. Any questions? So once again I request you all to send your feedback to the AIOC. And we hope to see you for the USI 2014 at Delhi in November.
I have a couple of cases of young ladies with autoimmune scleritis, no associated problems, but they go on for years and they are on methotrexate, high dose, but as soon as they go off steroids, they come back within a month, and they have to be on some kind of dose of steroids which they are titrating on their own now based on the symptoms. But they just can't seem to go off.
They don't respond to disease. Change the immunosuppressives. You can,
Is what they are on.
you can try azothioprine. If then they are not responding, they can afford. Then you can try MMF.
Yeah.
Or if it's a rule of vigilance and other things, if it is there, then cyclosporin with a close monitoring. Then that is also not responding, then we can switch over to biologicals. The biologicals, one is expensive, how long to continue. Second, with our country, the tuberculosis latent can get reactivated.
Good afternoon, everybody. In the beginning of the session, we have a keynote address by Dr. Vardhaman Kandre. Dr. Vardhaman completed a medical school from KM Hospital, and he completed ophthalmology from Sankaran Chennai. He was awarded Kathimathan Gold Medal and K. Vasant Madhavan Endowment Award as a Best Outgoing Resident. He completed Corneal External Diseases Fellowship under Professor S.K. Rao. Further on, he underwent Structural Clinical Research Fellowship in Corneal and Reticular Refractive Surgery in Greece under Professor Palikaris. He has presented numerous papers in various conferences in India and abroad, and also has several presentations in peer-reviewed journals like JRS, JCRS, Ophthalmology, etc. So we request Dr. Vardhaman to start this.
6 minutes for each speaker, please remember.
Thank you. So basically, it was almost the end of the presentation. As we have seen that it was seen to be not only effective in improving the best corrected visual acuity, improving uncorrected vision, and most importantly the safety concern, because we are using ablative profile now with the help of topographic guided PRK. However, in 2 years of follow-up or more, none of the patients had actually progressed. There was no endothelial damage. Therefore, in selected cases and in well-planned cases and in well-planned in Maruers, it is possible to combine these two treatments together, especially in eyes who are RGB intolerant, so that you can improve the functional vision for these patients, which was not possible before. Thank you so much.
Excellent presentation.
The minimum thickness was 450 microns. 450 microns. Thank you.
Yeah, Dr. Vardhaman, do you think 2 years follow-up is sufficient, or we should?
Yes.
What is the uppermost limit? At least.
So it is longer the better, definitely. But I think because this was the first center where this combination therapy was started, so that time we had only 2 years of follow-up. Now the follow-up is more than 3.5 years, and still none of them have progressed, and none of them have required a repeat CXL. Thank you so much. Thank you.
One more thing I want to ask: it was only topo smoothing, or it was to treat some refractor also along with this?
Yes. So actually it was customized. So basically in many of these cases it was only topo smoothing. But at the same time, in some of these cases where the corneal thickness allowed for some kind of refractive correction, at the same time we have done that as well.
Because you just wanted to treat 40 microns, so
yes.
That is usually the only smoking.
Absolutely.
Thank you.
Thank you so much. Thank you.
Our first speaker today, that is paper presentation, is implantable columnar lenses in keratoconus patient by Dr. Aniket Patil.
Dr. Aniket is here? Yeah. And we'll request the next presenter to have the presentation ready here on the next podium. Time allotted is 6 minutes. Please be stick to the time.
Good afternoon everyone, I am Dr. Aniket. Topic of my presentation is implantable columnar lenses, that is ICL, in patients of keratoconus, a definitive refractive solution. I would like to clarify here that none of us have any financial interest in the said study. Keratoconus, as you all know, is a progressive ectatic disorder of the cornea which is associated with progressive induced myopia and astigmatism. The sheer volume of refractive error and its irregularity has a significant negative effect on the quality of life of the patient with keratoconus. Visual rehabilitation of patients with progressive keratoconus is a challenge as it involves a two-step procedure. First is stabilization of the cone and then refractive correction. Stabilization of the cone is of primary importance for the long-lasting refractive correction. Current study evaluates the safety and clinical outcome of implantable columnar lenses, that is ICL, in patients of keratoconus post-stabilization with collagen cross-linkage. So current study was a retrospective study carried out at Nesarama Super Speciality Eye Hospital, Bangalore between January 2008 to December 2012 with a total tenure of 4 years. A total of 67 keratoconic eyes were included in the study. Keratoconus was first stabilized by collagen cross-linkage and later followed up by ICL implantation. The minimum duration between the two procedures was at least 6 months. We included patients with age more than 18 years, patients with stable refraction, patients with corneal pachymetry more than 400 micrometers, anterior chamber depth of more than 2.8 millimeters, endothelial count of more than 2000 cells per millimeter square. We excluded patients with corneal pachymetry less than 400 micrometers, anterior chamber depth of less than 2.8 millimeters, endothelial count of less than 2000 cells, any corneal opacity or scar, patients with peripheral marginal degeneration, any autoimmune or connective tissue disease. 26 patients underwent combined procedure in both eyes, whereas 15 patients underwent combined procedure in only one eye. A total of 67 eyes of 41 patients were included in the study. Females outnumbered the males. 61 eyes underwent collagen cross-linkage with ICL implantation, whereas 6 eyes underwent Kerr-ring insertion with collagen cross-linkage with ICL implantation. These 6 eyes were basically the patient with gross irregular astigmatism and grossly reduced visual acuity, but were not willing for any keratoplasty procedure. Coming to the age distribution, as expected, the major chunk of the patient was between 19 to 33 years, with majority between 24 to 28 years. Coming to the pre-op refractive error, majority of the patients had their spherical equivalent between 5.25 to 10 diopters, with a minimum of minus 1.62 diopters, a maximum of minus 25 diopters, and a mean of minus 9.75 diopters. Coming to the pre-op best corrected visual acuity, 50.75% had a pre-op best corrected visual acuity of 6/9 or better, whereas 74.63% had a pre-op best corrected visual acuity of 6/12 or better. Coming to the post-op uncorrected visual acuity after implantation of the ICL, 73.13% had a post-op uncorrected visual acuity of 6/9 or better. The pre-op figure here was around 50%. Whereas 85.07% had a post-op uncorrected visual acuity of 6/12 or better. The pre-op figure here was around 74%. Now coming to the post-op best corrected visual acuity, 76.12% had a post-op best corrected visual acuity of 6/9 or better, whereas 92.54% had a post-op best corrected visual acuity of 6/12 or better. If we compare the pre-op best corrected visual acuity with post-op uncorrected visual acuity, 39 eyes were status quo. That means they showed no improvement or deterioration in their visual acuity, whereas 18 eyes had an improvement of 1 line, 6 eyes showed improvement of 2 lines, whereas 2 eyes each showed an improvement of 3 and 4 lines. So in total, 41.8% of the eyes had an improvement in their visual acuity. We compared our studies with similar studies conducted in other parts of the world. Most of our results were comparable. Hence, combined collagen cross-linkage with ICL implantation was an effective and safe therapeutic approach in patients with keratoconus. What was universally known is collagen cross-linkage stabilizes the progression of keratoconus, and ICL is used for correction of high myopic astigmatism. My take-home message and what this study adds is combined collagen cross-linkage with ICL implantation provide excellent refractive results in patients with keratoconus, and sample size and duration of the study is longer than other such studies, emphasizing the long-term durability and effectivity of the combined procedure. These are my references. Thank you for your kind attention.
What is your long-term follow-up of these cases?
We are actually following up. The maximum that we have got is around 3.5 years. So this is a 4-year study. Minimum that I have got is around 1 year.
Have you seen any refractive changes over the period of these times? Because the effect of C3R continues even up to 2 years.
Yeah.
This progressive flattening of the cornea.
Yeah.
So have you noticed a change of number of these patients?
Most of them, whatever we've got, have been stable till date. There have not been any changes. And between the two procedures, that is between the C3R and ICL, we've kept a span of minimum 6 years. Those patients have progressed during the patients which have progressed in this span. We have not included them for ICL implantation. Even in doubtful cases, we have followed them over 6 months and then decided whether we should implant an ICL. It's only in those cases which have been stable over 6 months period and have a stable refraction, only in them we have gone ahead and put in an ICL.
So if you find that the refraction is progressing or changing, you will not do ICL in that case.
If the progression, if the keratoconus...
At 6 months you see that the progression of cylindrical power or the refraction is there.
Those patients we have not gone ahead and put in an ICL. That is one of our exclusion criteria. That
usually with C3R at 6 months we see that stability is not that common. Maybe only hardly 20-30% cases the stability is there.
We followed them up over the next 6 months then. Not that they have not undergone after many of the patients, the maximum duration one of the patients has undergone after 1.5 years. It's only after documentation that it has become stable, only then we have included them. Some patients which have become stable after 6 months itself, they have undergone ICL then itself after 6 months. But it's only after documentation of stability of the keratoconus that we have posted them for ICL.
How many of them were toric ICL?
59 were toric and only 7 were plain.
Most of them were toric.
Oh, most of them were toric.
So how much correction? You left over some cylindrical power because majority of them, they have very high cylinder.
Yeah.
Up to the tune of minus 10 diopter or so. You attempted full correction?
We attempted for full correction. We have attempted for full correction.
Or you have excluded with the high cylinder or?
What we had maximum was around 8. Around 8 and...
you cannot correct 8 diopter with ICL.
ICL gives plus 6, so those we have not included. Maximum that you can correct with ICL is 6, up to 6. Okay. So those which have been over that, we have not included in this time.
So you have left over some power?
Yeah. With keratoconus, it's not possible to treat each and every patient as it's a progressive disease. Plus, the volume of refractive error is not like ICL. Again, is available for spherical correction up to 23 only. Some patients even which we have up to 25 also. So there is a difference between post-op uncorrected visual acuity and post-op best corrected visual acuity. Some patients, despite of putting ICL, have gone non-progressed and need some correction after that also. You can't correct the whole refractive.
Loss of best corrected visual acuity is because of corneal irregularity.
Pardon me?
Loss of BCVA is because of corneal irregularity.
Okay.
Then why do you think was there improvement in BCVA after putting the ICL?
Loss of best corrected visual acuity is due to 2 reasons. First, the best corrected is due to the magnification effect of the minus lenses that you are using, which gets nullified if you put an ICL inside the eye, which is closer to your nodal point of the eye. Hence, the magnification effect goes off, so that kind of improvement is expected and will happen in patients.
What was the any limit for keratometry for selection, inclusion?
Actually, we didn't include it. It's advisable to keep it around 60. But what we had done is patients with which was stable after this C3R, we included them in the study. We didn't put any upper limit. But it's advisable to keep it around.
Any specific made for the keratoconus for ICL, or it was the same routine ICL?
It's the routine ICL. There's no specifically.
So Dr. Balika was saying that you are putting a cylinder correction in one meridian, and the keratoconus other meridian is not corrected, and it will induce some cylinder. So I think quality of vision will not improve much.
As far as we have not checked the quality of the vision. Quantitatively, what we have done, Snellen gives us only quantitative vision. So quantitative vision is quite good. So quality of vision we'll have to check and then know about it. It's not done.
Thank you.
Okay, thank you.
Now we call upon the next speaker. A study of corneal biomechanics in normal and keratoconus eyes, comparison between the corpus, ST and ORA. The presenter is Dr. Karishma Wadia.
Thank you, sir.
Your time starts.
Okay, so I'm here to present about the correlation between the two biomechanical machines, that is Corvus ST and ocular response analyzer, and I've compared corneal biomechanics in normal versus keratoconic eyes. So we all know about the conventional machine, that is the ocular response analyzer, that has been there all this while to study patients of pre-LASIK, refractive surgery and ectasia. The newer machine is Corvus, which is basically corneal visualization using shine flux technology. It provides real-time imaging based on corneal deformation to an air puff, and it gives you ultra-high speed shine flux images. So both these machines are based on similar principles of the air puff applanation or the distortion of the cornea, and both of them provide totally different variables. That is why we carried out the study. It was a prospective non-randomized observational case series. We studied normal eyes and keratoconic eyes with various parameters. So in our study we had 25 keratoconic eyes and 62 normal eyes. First we talk about the biomechanics part in the keratoconus group versus the normal group. The table to the left has values of keratoconus group. As you can see, first we tried to compare CH, that is corneal hysteresis, versus deformation amplitude of the corpus. The R value using Pearson's correlation is very poor. It's only 0.01. Then we try to compare the CRF with deformation amplitude. Again, we saw that there's a very poor correlation. But if you compare CH and CRF, then obviously we already know they're of the same machine, so they speak the same language, there's an excellent correlation. If you see in the normal group, again, the corneal hysteresis versus deformation amplitude and the CRF versus deformation amplitude have no correlation. So basically, ORA and Corvus are speaking entirely different things in terms of biomechanics for both keratoconic eyes and normal eyes. And in the ORA, of course, CH and CRF are showing a good correlation. Further on, we compared the values of intraocular pressure in keratoconic and normal eyes. In the keratoconic group, again, Corvus ST shows an IOP, which we compared with the IOP CC of ORA. The R values had a very poor correlation. We also compared it with the IOP Goldman's of ORA, again, poor correlation. In normal group also, both the values, Corvus ST IOP and with IOP CC and with IOP G have a poor correlation of only 0.25 and 0.51. So essentially, in the keratoconus group, IOP measurement on ORA did not show any correlation with that on Corvus ST. In normal individuals, IOP G, that is the Goldman's IOP of ORA, showed a fair correlation with the Corvus ST IOP, but that did not show much with the IOP CC. But of course, this could be due to a very small sample size. We had only 29 keratoconus and 52 normal eyes. So to conclude, basically both of the machines, even though they are studying corneal biomechanics, they have no good correlation in what they are measuring. So they cannot be used interchangeably. They don't give you the same information, they provide you different information. But of course, follow-up on the same machine is mandatory. So you cannot use the Corvus instead of the ORA, nor can you use the ORA instead of the Corvus. You probably need both.
We need both or you have said that it is not interchangeable.
Not interchangeable.
Means if someone has got Corvus, he can follow, that person can follow on Corvus machine.
Possibly, but then the reliability of the Corvus alone is still what we are trying to analyze. So when we use the Corvus itself, by itself, without any ORA with it, we also see that within inter-patient variability is also there. So we are currently taking 3 readings for each patient so that we get a mean value of them and then we follow them.
But with the ORA also it is the same?
Yes, with ORA also it is the same.
It's not reliable.
It is.
ORA is not even.
The repeatability is not there in both machines. But what you have done for follow-up means the patient of keratoconus might progress. You have not done any treatment.
This is not for that. This is
So that's
only
what I'm
we are
saying.
just, yes.
So what you want to see is the reliability and predictiveness on the follow-up.
Yes.
If you have not stabilized the keratoconus, how it will be there?
No, these are for
Keratoconus patient can keep on having change in the biomechanics.
Absolutely.
So how do you rule out that?
So there are 2 types of, not a part of this study, but there are 2 different studies that have been carried out using the Corvus itself. One is to show that the keratoconic eyes, the biomechanics as it changes when there is progression and then it stabilizes after cross-linking. In that again we have compared Corvus versus ORA for treated and untreated progressive eyes. So of course that is a different study altogether. But again both of them, they don't have any correlation. Within Corvus itself, it will show similar values. That when you're progressing in keratoconus, your Corvus values, your deformation amplitude, etc. increases. Once it stabilizes, the deformation amplitude remains the same, just as would happen in everyone.
So out of the 2, which one you feel is better for checking up as a follow-up?
Right now, the Corvus ST gives us the deformation amplitude, which immediately explains to us how much the cornea is deforming. So, in terms of quantifying how weak that cornea is, I feel that the Corvus would be best.
And any patient you have done the post-disease study, how much is the change in biomechanics, and you can report that? No. And what was your average CRF for keratoconus patient, and what was the average for normal?
It is much
not
higher.
very big.
Yeah, it is much higher for keratoconus patients as compared to the
No, CRF is less than average keratoconus, more
Yes.
than 10 is normal.
Yes.
10 is without. So you would not find any mean value for this patient.
No, sir, we haven't.
Yeah, thank you.
Wait, Dr. Krishna, can you continue the next topic?
Yes.
You are supposed to speak on normal gums for keratoconus treatment.
My next presentation is on nomogram for keratoconus treatment. we already know that there are multiple options available to treat keratoconus, whether it is stable or progressive. But the question is what to use when, and also we need a simplified algorithm to tell us how to use these multiple treatments. So in our nomogram, we have classified keratoconus into 3 types: stable, progressive, and advanced. I'll be discussing each of these in the part of my presentation. So coming first of all to stable keratoconus, this is something where we're not worried much. We're only bothered about refractive correction. So if the patient is happy with glasses, then of course we would want to stop right there. But to give a better quality of vision, we have a multitude of lenses that are available, starting from the normal RGB lenses to the rose scale lenses to the more recent mini scleral rose scale lenses. Whatever is suitable for the patient in terms of cost is also required. For a large residual area error, you can always use an ICL or a toric ICL. The main principle of treatment for progressive cases would first of all be to halt the progression. The secondary outcome is always a refractive outcome. The first is always to halt the progression. And again, if there's a large residual error, you can always give an ICL after stabilization. So in the primary treatment, that is cross-linking, you again have 3 types: conventional, accelerated, and transepithelial. The main difference between conventional and accelerated is that wherein conventional we used 3 milliwatts for 30 minutes, we now use 30 milliwatts for 3 minutes exposure. But at the end of it, the same amount of energy is on the cornea, which is 5.4 joules. So if we're treating the progression, we can also have an ablative treatment along with that, or a non-ablative treatment. In ablative treatment, we're talking about topo-guided treatment, which is similar to what Dr. Vardaman discussed. And non-ablative treatment is ATACs. Now for these progressive keratoconuses, again, you would want to first divide them into central keratoconus and decentered keratoconus, and then plan your management. If you have a central keratoconus, then anyways the visual outcome after you have stabilized is going to be relatively good. So you can just give them glasses or contact lenses. Or you can give them a symmetrical intact ring and then glasses or contact lenses. For a decentered cone, however, our approach is going to be different. So what is a decentered cone? So first of all, a centered cone would be one which has the highest point of elevation within the central 3 mm zone. The exactly converse would follow for a decentered cone. Why the change in approach for them is because of 2 things. First of all, you want to improve their tolerance to glasses or contact lenses, so that when you have stabilized or when you have centralized their cone, then the refractive outcome and the comfort of the patient is better. What I'm first talking about is a topo-guided treatment. So if you have a topo laser-guided ablation profile like this one, you can also couple it with an intact. That is a sequential treatment. So you first do topo-guided treatment, then you do an intact. In the topo laser-guided ablation, you get a map of the keratoconus which is already existed. You get an ablation profile, and if you superimpose it and see, it pretty much ablates where the cone needs to be centralized. It gives you an ablation profile in terms of what Q value has to be treated, what refraction has to be treated. You can either treat the refraction or only treat the topography, whatever you want. A simple example of a decentered keratoconus which after treatment has become centralized. The second option is an intax. In intax, again, you can use it as a primary treatment itself or sequentially after topo-guided ablation. Again, you have 2 types of rings, an SK, which is an oval cross-sectional ring for steep corneas more than 55 diameters, and a regular ring, which is a hexagon ring cross-section. We have a separate nomogram for intax, which has also been published in the recent version, in the recent edition of AIOC, but for the want of time, I won't go into the details of the intax nomogram right now. This is again another example of an asymmetrical SK ring with a spot. After you put the rings, immediately the cone becomes centralized. There is improvement in the post-op unaided visual acuity, best correctives, and spherical equivalent. The last branch of the nomogram is the advanced keratoconus group, which is basically for those who have severe thinning where you can't do a C3 or post-hydrops and scarring cases. This is a very simple branching. If there is no scarring, you can directly go in for a DALK. If there is scarring, you go in for a femto-enabled keratoplasty. The visual outcome is very good in terms of graft clarity. There is minimal interface haze. And in the femtosecond enabled keratoplasty, the advantage that you have is that first of all, it is a mushroom-shaped fit that you choose for, so the apposition of the graft to junction is very good, and minimal sutures. There is only 8 sutures can be used. In the DALK group, there is improvement in the mean astigmatism and the unaided visual acuity, as there also is in the femto-enabled group. There's a dramatic improvement in the unaided visual acuity in pre-op and post-op cases, and this is maintained even at the end of 1 year. There's also a drop which is significant in the spherical equivalent and astigmatism. To conclude, a mushroom-shaped femto-enabled keratoplasty is a safe procedure. It has faster visual rehabilitation and faster topographic stabilization. There's also lesser sutures and lesser suture-related complication. So coming back to the nomogram, it simplifies your treatment options. It gives you a simple algorithm, tells you what to use when. Even though you have so many options in front of you, you exactly know what to use when you are faced with the patient. Thank you.
So Krishna, you said that you will do topo-guided treatment first and then you will do Intex.
Yes.
The Intex itself is going to change the topographic profile of the body.
Intex with the rings can treat up to 3 to 4 diameters.
No, but it is going to change the topography.
Yes.
So you should do before first Intex and then you will go topo treatment of the remaining.
The problem with that would be that in the topo-guided treatment after an Intex, if you are ablating on top of the Intex, then the rings can get extruded.
They are 350 micron deep from the surface and
Yes.
you are not going to ablate more than 100. Or usually the upper limit is 40-50.
But the
if you
topographic...
don't treat even the refractive error, you cannot be more than that. What I mean to say is that when you do Intex, it is going to change the topography of the cornea. And if you do a topo treatment first, what for HUDR into Intex is changed.
You are only putting the Intex if at the end of the topographic treatment, it has not received the visual outcome that you desired.
Intex alone can keep the cone in the center. You can make a cone in the center. If it's not there, then you can do additional treatment with the possible.
But for very advanced decentered cones, very high case, if you put an Intex, you still have some residual
Actually, that is what we want to say. You should treat the residual part rather than treating the primary and having the Intex as a second.
First Intex.
Yeah.
Then
But if you are doing a topo-guided treatment, you are going to be also ablating the part opposite to where it is steep. So then that might go outside your Intex ring. Then where is the effect of the Intex?
Probably be service with the topo. You will just treat the topo almost on the cornea, wherever it is. Inside the ring, outside the ring, over the ring, does not matter. You are actually making the cornea much more smoother for topographic part for a better quality vision by other means. Sometimes it can be there without correction also, but usually it is by correction.
Next talk is by on nomogram is already transepithelial PTK photorefractive keratotomy combined with CXL for pellucid marginal degeneration by Dr. Bharatman Kakariya.
Thank you, sir. I actually take from where I stopped in my last presentation, and this is going to take one notch higher. We dealt with keratoconus and we dealt with topographic guided treatment. Now here, how are we going to deal with this? Is going to, we are going to make it more refractive. So what are we going to look at, and what I'm going to share with you is our pilot study results of simultaneous conventional PRK and collagen cross-linking for pellucid marginal degeneration, a prospective pilot study. This study has been funded by the clinical grant of the Hellenic Republic University of Crete. Pellucid marginal corneal degeneration is a progressive, non-inflammatory ectatic corneal disorder that leads to inferior corneal eccentric thinning, protrusion, and gradual visual decline, and especially because of very high corneal astigmatism. It is proved beyond doubt that collagen cross-linking has been successful in stabilizing cornea mechanically and halting progression of various corneal ectatic disorders, including PMD, keratoconus, post-LASIK, ectasia. But what we have known since so many years that we have been using all this modality is that many of these post-CXL patients do not achieve visual acuity improvement sufficient to provide them functional vision, and that is probably more important, especially when they cannot tolerate contact lenses or spectacles, and it is basically because of remnant regular as well as irregular astigmatism. So as I discussed before, it was Quinones from our group who devised the first combination therapy of topo-guided PRK along with CXL for keratoconus to improve best corrected visual acuity and to regularize the cone. After that, in the same year, we also published a case report in which now the topographic guided PRK with CXL was used also in PMD to significantly improve visual outcomes as well as topographic outcomes, and this has been published in Journal of Ophthalmology. But what we are going to see here is a few patients in PMD subgroup in our experience has demonstrated a fairly regular astigmatism, not irregular but fairly regular astigmatism, and they still have a good best corrected visual acuity, although they have very high astigmatism. These patients, although could be corrected with spectacles, but they are intolerant because of either anisometropia between the eyes or very, very high astigmatism. And in many of such instances, they are also either intolerant or they don't want to use the contact lenses. So now the question is, can conventional PRK can be combined with CXL as an effective combination, and is there a rationale and safety for this itself? My purpose here is to present visual, refractive and topographic outcomes of conventional PRK with CXL for progressive PMD with spectacle and contact lens intolerant. In this prospective interventional study, patients were recruited after IRB approval following the institutional guidelines, in which the patients with progressive PMD who still had a good best corrected visual acuity, non-tolerance to spectacles or RGB contact lenses, and a relatively good thinness pachymetry more than 450 microns were recruited. These patients were subjected to combined treatment by the same surgeon, in which first the epithelium was removed by transepithelial PTK of 50 microns, which was slightly decentered inferiorly, which was followed by a conventional PRK with the help of alligator web light, in which depth was restricted as in before, less than 40 microns of thickness for partial PRK and less optical zone of 5.5 millimeters. CXL was then performed with a standard Dresden protocol. Visual, refractive and topographic outcomes were evaluated along with endothelial cell density preoperatively and 1, 6 and 12 months postoperatively in these cases. Total of 48 eyes with PMD have undergone cross-linking in our setting, in which 8 eyes of 6 patients have been enrolled and underwent this specific combination therapy and have at least 1 year of follow-up were recruited. As we can see here from this chart, all the variables such as spherical equivalent, corneal astigmatism and steep keratometry demonstrated statistically significant improvement at last follow-up of 12 months, and this also reflected in statistically significant improvement in uncorrected visual acuity. As we can see here from this chart, mean uncorrected visual acuity was 1.05 logmar units preoperatively and improved significantly to 0.4 logmar units at 12 months postoperatively. At all the postoperative intervals, you can actually see the statistical significance as compared with perioperative. And while the best corrected visual acuity was improving slightly, however, did not show any significant change per se. Only 12.5% of these eyes had uncorrected visual acuity of 20/60 or better preoperatively, which improved significantly to 85% of the eyes. And when coming to safety, none of the eyes lost more than 1 line of best corrected vision, and in fact 30% of them actually gained 1 or more line of best corrected visual acuity, and probably this is the effect of transepithelial PTK at the same time. There were no intra or postoperative complications. The endothelial cell density was not significantly different, and none of the eyes demonstrated progression over time. So basically we chose to perform a PTK PRK instead of topographic guided PRK in these settings because preoperative best corrected visual acuity was giving patient functional vision. On the contrary, in topographic guided PRK is utilized only if there is irregular astigmatism. The conventional PRK ablates also less amount of corneal tissue as compared with topographic guided PRK, as we understand, and it's also more predictable. As we can see here from this case example, this is a 48-year-old lady who came up with approximately 6 diopters of astigmatism, had PMD, was progressing, and we treated her with conventional PRK along with cross-linking at the same setting. As we can see, best corrected visual acuity even at 1 year of follow-up is similar. However, her uncorrected visual acuity has improved from 660 to 612, and she was one of those, because of very high anisometropy and intolerance, was not able to use her spectacles very well, so is now very happy. So to conclude, simultaneous PTK PRK combined with CXL seems to be an effective and safe promising treatment for management of selected PMD patients in our pilot study. Larger patient series with longer follow-up is definitely required to evaluate outcomes of this combined treatment. And I would like to thank my team. I would like to show you my references, and thank you for your kind attention. Thank you.